I am delighted to introduce our next presenter, Missy Travis, with an impressive 20 years of experience in infection prevention techniques. Missy has made significant contributions in a diverse range of healthcare settings. Throughout her career, Missy has worked in acute care hospitals, large teaching university medical centers, inpatient rehab hospitals, sports teams, and public health settings. This breadth of experience has equipped her with a deep understanding of the complexities of infection prevention across various environments. Missy's commitment to excellence in her field is evident through her educational achievements. She holds a Bachelor of Science in Nursing from the University of Kentucky, a Bachelor of Science in Nursing Arts from Georgetown College, and a Master's of Science in Nursing from Vanderbilt University. As a registered nurse in Tennessee and a certified in infection control, Missy's expertise is both broad and specialized. Her dedication to advancing infection prevention practices and her wealth of experience makes Missy Travis an invaluable resource to our boot camp today. And as this time, I will stop sharing my screen and welcome to Missy as we explore strategies to enhance our defenses against infectious diseases. Missy, I'm going to hand it on over to you.
Thank you so much, Julia, and thank you for that introduction. Okay, can you see my screen all right?
I can absolutely see your screen.
Okay, well, thank you guys so much for joining me today to talk about this hot topic of enhanced barrier precautions. Let me stop my video here just so you all can focus on on my slides. So you all have probably heard a lot, seen a lot about enhanced barrier precautions over the last several months. Really, it's been going on for the last several years, but was somewhat eclipsed by the COVID-19 pandemic. And now we're starting to see more and more information and updates to enhanced barrier precautions. So today, I'm going to try to simplify for you enhanced barrier precautions. We're going to talk about what they are, when they apply, and try to give you some simple strategies for how to implement enhanced barrier precautions in a long-term care facility. So our objectives for today is I want you to be able to describe the purpose of enhanced barrier precautions, assess when enhanced barrier precautions are indicated, and apply enhanced barrier precautions in a long-term setting. And now I know there may be some of you all who are in an acute care facility, and I don't want you to just tune me out and leave the boot camp because some of this will be applicable to you as well. Even though these primarily apply in the long-term care setting, we're going to talk about in a little bit why this is still applicable to some of our other settings in the community as well. So first, let's talk about why do we even need enhanced barrier precautions? You know, we already have transmission-based precautions, we have standard precautions. Why do we need another set of precautions? Well, some studies were done when they were developing EBP, and they found probably one of the most startling statistics is more than 50% of residents in a nursing home may be colonized with a multi-drug resistant organism, as well as nursing homes being the setting for an outbreak. And then, as Chad just went over in his excellent presentation, we know there are limited treatment options for a lot of these multi-drug resistant organisms. And in addition to that, we know that long-term care facilities have had difficulty implementing transmission-based precautions, specifically contact precautions. And we'll talk a little bit more about that in a moment. So as I mentioned, that the statistic for residents in nursing homes, we also know that they are at an increased risk of becoming colonized and or infected with a multi-drug resistant organism, because not only is there the presence of MDROs among other residents, but we also know that these are some of our most vulnerable people who are in our population because of advanced age and other comorbid conditions. We know that contact precautions are challenging to implement due to the use of personal protective equipment and room restrictions, because contact precautions requires that you put on PPE for every interaction with a patient or a resident. And whenever you're working with residents in a long-term care facility, that can be difficult for many reasons, but also we want to give them a little more freedom in a long-term care facility and impose the least amount of restrictions because this is also their home. That's oftentimes our challenge in infection prevention is trying to balance the safety along with the dignity and giving those people the right to have a home where we are restricting them for the least amount possible. And then also with contact precautions, oftentimes we apply a room restriction. In an acute care facility, oftentimes they do not leave their room unless it's absolutely necessary that they leave the room. But for the most part, they're going to stay in their room. And that's really not feasible for a resident in a long-term care facility for them to stay in their room at all times for multiple reasons. Most long-term care facilities implement additional infection prevention measures for residents with active infection. So as I mentioned, it is difficult for them to implement contact precautions in many circumstances, but we do know that if they have an active infection, then oftentimes they will impose those restrictions, which really is not unreasonable. When you have someone who is actively ill, asking them to stay in their room is not an unreasonable ask, as much as when we know that someone might be colonized with a multi-drug resistant organism and basically telling them you've got to stay in your room for the entire time that you live in this facility, which seems a little more unreasonable. We also know that multi-drug resistant organisms can be transmitted from colonized residents who do not have any symptoms of illness. And this is really where the issues come into play because as I mentioned at the beginning, 50% of them may be colonized with a multi-drug resistant organism. And we also know that they can transmit those to other residents. And when you think about these long-term care facilities where we are, promoting people to be together and to be out in these group areas and to have contact with each other for various reasons, that also has some infection prevention implications. And so that's where enhanced barrier precautions come into play. So what exactly are enhanced barrier precautions? Well, in general, infection prevention precautions that are implemented in addition to standard precautions in a long-term care facility for a specific group of residents. So this is for a specific group. And it requires targeted use of gowns and gloves with high contact activities, and it does not require room restriction. So we kind of address in that previous slide, I talked about two of the reasons why it's hard to implement in long-term care facilities, why transmission-based precautions are hard to implement. So enhanced barrier precautions, in essence, is trying to address those. And I like to think of enhanced barrier precautions as somewhat of a hybrid between contact precautions and standard precautions. They're less restrictive than contact precautions, but they require more PPE use than standard precautions. These two most recent documents from CDC describe the rationale for implementing EBP. And the other thing that makes EBP unique is the application really considers the risk of transmission as seen in the studies done in long-term care facilities. So only high-risk activities are included and only high-risk residents are included. And that will make a little more sense to you in just a minute as we go a little further through the presentation. So the other thing that kind of muddied the water, so when you look at these two studies here, actually some documents came out early on in the 2000s, but the ones that really started bringing attention to EBP were these two in 2021 and 2022. Well, last month, CMS, not wanting to feel left out, decided that they were also going to release a memo stating that they were going to start citing facilities for not using EBP correctly or for not implementing EBP. So at the beginning, when CDC first released the EBP recommendations, some long-term care facilities were hesitant to implement enhanced barrier precautions just because they were still kind of in the aftermath of the COVID-19 pandemic. And maybe there was a lack of understanding about how to implement them. And it was just more of, we have decided we're not going to implement them at this time. Well, now that CMS has released this memo stating that they will start citing facilities for not implementing and using EBP regulations, that somewhat changes that. And so now it really forces the hands of long-term care facilities and that they do need to implement enhanced barrier precautions, not only because it's a best practice, but now because they will be cited from CMS if they are not implementing EBP. So as I mentioned earlier, for EBP, we're only focusing on high contact activities. And so this is one of those distinctions between EBP and contact precautions. As I mentioned at the beginning, for contact precautions, we train healthcare providers. You put your gowns and gloves on at the door before you even go in. You need to have your gowns and gloves on. EBP is different in that that's not going to be something you're going to do automatically. You're only going to wear gowns and gloves if you're performing high contact activities. So what are some of the high contact activities? Well, I have them listed here on the slide. They are dressing, bathing and showering, transferring, providing hygiene. And I want to talk about this one specifically for just a minute because a lot of questions come up about what does providing hygiene mean? And providing hygiene refers to practices such as brushing teeth, combing hair, and shaving. And CDC defines this as these are commonly bundled together as part of morning and or evening care. And so they say that you do not have to wear gowns and gloves if you're just doing one of these things. Like if you just go in and help someone brushing their hair, you would not have to wear gowns and gloves. It's really if you're bundling several of those things together that you would want to wear gowns and gloves, because really it's those high contact is what we're looking at, that prolonged contact with a resident. It's also important to note that these were not just pulled out of the air. These were actually studied, and they noted that these were the activities that it was most likely that organisms could be spread from the resident to the healthcare provider's hands or clothing. And so that's why we're focusing more on these high contact activities and not just everything that you might do when you go into a resident's room, which is what we do with contact precautions in an acute care facility. Changing linens is another one. And so this one's also important to note because sometimes I will have facilities ask, well, we're not going to train EVS on EBP. That was EVS and EBP because, they're not going to be doing any high contact activities. Well, this is one high contact activity that might involve EVS if they have the responsibility of changing linens. So especially if they're, doing a room at discharge, or if a resident has been transferred for whatever reason and they're responsible for changing the linens, then it would apply to them. And so it is important that they also understand what enhanced barrier precautions entails. Changing briefs or assisting with toileting, device care or use, so specifically central line, urinary catheter, feeding tube, tracheostomy or ventilator. And then wound care. And we're going to go a little bit, I'll tell you a little bit more specifics on the next slides about wounds. But basically, we're talking about wounds, which are defined as any skin opening requiring a dressing. But we're going to talk a little bit more about that in a moment, because lots of questions have come up recently about wounds and what exactly is included. So for enhanced barrier precautions, we have a similar sign like what we use for the transmission-based precautions, which tell you what should you do. Of course, we always want to do hand hygiene before and after. And then it tells you what you need to wear when. So it has listed out what are those high contact activities. And then, of course, some other pointers like do not wear the same gown and gloves for the care of more than one person. And this sometimes can be tempting in long-term care facilities because a person who is on enhanced barrier precautions can be in a semi-private room. And so you might have a resident that is on EBP and one that is not. So as I mentioned earlier, we are wearing gowns and gloves when performing high contact activities. It's used for patients who are not in contact precautions. And so if contact precautions apply, then EBP does not apply. So it's either one or the other. So you do not have both applying at the same time. And then it applies to patients with the following: wounds and or indwelling medical devices, regardless of multi-drug resistant colonization. And this is something that's a little different than what was proposed at the beginning. So what this means is regardless if you have a multi-drug resistant organism, if you have a wound or an indwelling medical device, you go on EBP. And I'll tell you, it took me a while for that to sink in for me as well, because we're so used to only looking at their MDRO status that I had to really think about this. And it may take you a while for this to sink in as well. So it's anyone with a wound or indwelling medical device, regardless of MDRO colonization. And then also infection or colonization with a novel or targeted MDRO when contact precautions do not apply. So I know this sounds a little muddy, so we are going to define this a little bit more in the coming slides, but I wanted to give you an overview of enhanced barrier precautions before we really get into the weeds with some of these definitions. So the first definition is, what is an indwelling device? So an indwelling device, according to the CDC guidelines for EBP, it provides a direct pathway for a pathogen in the environment to enter the body and cause infection. And so another way that I've heard it described is it's a device that is fully embedded and has communication to the outside of the body. And I kind of like how they added that communication to the outside. And so this includes central lines, feeding tubes, a urinary catheter, a tracheostomy. It's important to note that peripheral intravenous catheters are not included in this category. That's probably caused the most confusion among facilities, but that is not included as an indwelling device. Also, implanted glucose monitoring devices are not included because there's no communication to the outside. Also, pacemakers are not included. So really think about, is it communicating to the outside of the body? Also, an unaccessed port wouldn't be included. If the port is being accessed, then it does have some communication to the outside. So then we would include it at that point. So similar to a lot of our guidelines, when they first come out, we think, oh, this is not going to be any problem to implement. And then we start getting into some of these situations and you quickly realize, oh, there's a little more to this. And so as these questions have come up, CDC has continued to clarify what is included and what is not included. And so you can find a lot of those questions in their FAQ, which I will point out at the end when we look at the references for this presentation. So the next big question that comes up frequently for EBP is what kind of wounds are included? So the wounds that would generally be included in EBP are chronic wounds and not those with only a shorter lasting time frame, such as a skin break or a skin tear with a small band-aid or a small little 2x2 over it. We're talking more about a chronic wound, something that we anticipate is going to last for a long period of time. And some examples of chronic wounds are pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, and chronic venous stasis ulcers. Another question that has come up frequently is, are stomas included? And the answer is no, they are not included in this group. So really we're thinking about those that require a dressing, a chronic wound, and just keep in mind simple skin tears are not included because residents in long-term care facilities may get simple skin tears. So those should not be put on EBP if it's not a chronic wound and one that requires a dressing. So the other question that comes up frequently is what multi-drug resistant organisms are included? And so it's the multi-drug resistant organisms targeted by the CDC are the ones that we are primarily looking at. And so there is a specific list, and this came at the perfect time for me to do this presentation directly after the last presentation because we just talked about a lot of these multi-drug resistant organisms that are being targeted by the CDC. So pan-resistant organisms, ones that are completely resistant that we talked about earlier. Carbapenemase producing carbapenem resistant Enterobacterales. That's another group we just talked about. Carbapenemase producing carbapenem resistant Pseudomonas species. Carbapenem producing carbapenem resistant Acinetobacter baumannii. And then Candida auris. So these are the main ones that we are looking at for enhanced barrier precautions. Now, there is another set that can be included, and really it is according to what's going on in the community. And if your local health department or state health department have deemed them epidemiologically important MDROs. And this could include MRSA, ESBL producing Enterobacterales, VRE, other multi-drug resistant Pseudomonas, and drug-resistant strep pneumonia. And so if you talk to your health department, your state health department, or your local health department, they should be able to help you determine if one of these should be in your plan for your facility as a part of enhanced barrier precautions. So another big question, because as I mentioned earlier, was, EBP only applies when contact precautions does not apply. So that begs the question, well, when does contact precautions not apply when we're talking about enhanced barrier precautions? So specifically, they do not apply if secretions or excretions can be covered or contained. Now, this is a difference for those of us who come from acute care, because when we have a wound that is draining, we automatically put those people in contact precautions. So this is a caveat for EBP. So if they have a wound that is draining, it doesn't automatically go in contact precautions if that drainage can be contained. So another little caveat there. So if they have a wound and it's draining, but it's able to be contained, they would not go into contact precautions. They would go into enhanced barrier precautions. A non-acute diarrhea. So if they have C. diff, they're still going to go into contact precautions just like before. But if it is a non-acute diarrhea, like the reason why they have diarrhea, or it's a chronic condition, again, if it can be contained, they're going to go into enhanced barrier precautions. MDROs when not in an outbreak situation. So oftentimes, so that was another question that came up with EBP because we're used to when you have MDROs that they would automatically go into contact precautions. And that may still be the case. Like if you're having an outbreak of Candida auris and you're continuing to have new cases that are popping up and it's not really under control, then in most instances, you're going to keep everyone in contact precautions until that is under control and until you have permission from the public health department that you can start using EBP instead of contact precautions. So also in the absence of a public health directive. So if your public health department has said everyone needs to go into contact precautions, you're going to follow their directive until they say, okay, now we can transition over into enhanced barrier precautions. And mostly that's going to be in some sort of an outbreak situation when other infections are not present. So as I mentioned, if someone has C. diff, they're still going to go into contact precautions. So we're not totally doing away with contact precautions. We've just provided this other category for some of these other types of illnesses, as well as we're including some other situations, those high contact activities for certain residents. Norovirus, you would still use contact precautions, scabies, and really any of the other conditions listed in Appendix A in the CDC guideline for isolation precautions. You're still going to use transmission-based precautions in some instances. It's also important to note that residents in EBP do not have to be in a private room. Gown and gloves are not required for resident care activities other than those listed, unless otherwise necessary for adherence to standard precautions. So standard precautions is always applied across the board. And most of us know that infection prevention, that we always use standard precautions. And so if you're just going in to drop off a tray for a resident on EBP, you're not wearing gowns and gloves. If you're doing anything other than those specific activities that we talked about earlier, you're not wearing gowns and gloves. You're just doing standard precautions. The big one is residents are not restricted to their room and they're not limited from participation in group activities. One other thing to note is it does apply for the duration of a resident's stay in the facility or until the resolution of the wound or discontinuation of the indwelling medical device that placed them at a higher risk. So for instance, if you have a resident that you know has one of those multi-drug resistant organisms that we discussed earlier, those residents in general are going to stay on EBP for the duration of their stay in the long-term care facility. That being said, if they're on EBP because of an indwelling medical device, for instance, say they have a central line, once that central line is discontinued, if they don't meet any of the other criteria, they don't have an MDRO, they don't have a wound or another indwelling medical device, at that time, you could discontinue enhanced barrier precautions. The same for the wound. If someone comes in, they have one of those chronic wounds, but over the next several weeks, the wound heals, it closes, they don't meet any other criteria for enhanced barrier precautions. At that point, that you could discontinue enhanced barrier precautions for that resident. So this is a great table to go over with your staff and review with them because it really spells out when standard precautions apply, when enhanced barrier precautions apply, and when contact precautions apply. And I oftentimes refer to this because, as I said, this is a little different for us, even in infection prevention. We're not used to some of these caveats. And sometimes I have to go back and look at it again and really make sure that I'm telling someone correctly if that person goes in enhanced barrier precautions. And this comes directly from the CDC guidelines. And so you'll see for standard precautions, this applies to all residents. You know, any potential exposure to blood, body fluids, mucous membranes, non-intact skin, this has not changed. We're still looking at any anticipated exposure where you would apply gowns, gloves, face mask, eye protection, etc. So this really is based on what are you doing with that resident? What is your level of risk? And so we're very familiar with standard precautions. So that nothing changes with standard precautions. So enhanced barrier precautions, it applies to all residents with any of the following: an infection or colonization with an NDRO where contact precautions do not otherwise apply. We talked about that, when contact precautions would not apply. Wounds and or indwelling medical devices. We talked about what was an indwelling medical device, and we also discussed what is considered a wound in terms of EBP. And so then when we get to that column, PPE is used for these situations. It's only during high contact resident care activities. And we talked about that specific list. It's only during these specific activities. It's not every time you enter the room. It's only if you're doing a high contact activity. And then the required PPE is gloves and gown when you're doing those high contact activities. Now, keep in mind, standard precaution still applies. So if you are suctioning someone or doing something else where you might require a mask or eye protection, that still applies just like it does for transmission-based precautions. Now notice that last column for standard precautions and enhanced barrier precautions for room restriction, because this is big in long-term care facilities. There is no room restriction for either of those types of precautions. So let's go down to contact precautions, which this is the most restrictive. And remember, I said at the beginning of the presentation, I see enhanced barrier precautions kind of as the hybrid or the middle child, if you will, between standard precautions and contact precautions. You have the least restrictive is standard precautions that applies to everyone. The most restrictive is our transmission-based precautions, and then enhanced barrier precautions is kind of in the middle between the two. So contact precautions, all residents infected or colonized with an NDRO in any of the following situations: the presence of acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be covered or contained for a limited time period as determined in consultation with public health authorities on units or in facilities during the investigation of a suspected or confirmed NDRO outbreak. So that was like what I was saying earlier about Candida auris. We're in the middle of an outbreak. We're still having cases. Most likely we're going to be in contact precautions. And then when otherwise directed by public health authorities. So all residents who have another infection such as C. diff, norovirus, scabies, or a condition that would require contact precautions such as lice, or is recommended in Appendix A, those are still going to apply. So when you look at PPE used for this situation, you see for contact precautions, it's any room entry. So we don't go into the room without putting on our gowns and gloves. Required PPE, gloves and gown before you enter the room and taking them off before you exit the room. And then room restriction, yes, except for medically necessary care. So I love this table because I feel like it really does a good job of explaining. So if I have not done a good job explaining to you through my slides when each of these are applied, then hopefully the use of this table will give you some more clarity about when you would use each of these types of precautions. And definitely, if you're working in a long-term care facility, I would have this table readily available so that you can go back and look at it frequently. So let's review some key points for isolation. And this is just used in general, but also is going to apply for enhanced barrier precautions. You want to have a sign on the door to the room. Now, another big question that comes up in long-term care facilities is it a HIPAA violation to put a sign on the door? It's not a HIPAA violation if you're using that sign from CDC that I showed you earlier in the slides. Now, you cannot put a sign on the door that says MRSA infection or C. diff infection. You can't do that, but you can put a sign on the door that says enhanced barrier precautions, because we have to be able to communicate with other healthcare providers so that they know that that precaution is in place. You want to make PPE readily available for PPE donning. So that was mentioned in one of the prior presentations. You know, it can't be down the hall where they're not going to be able to get to it quickly. Because the reality is, especially with EBP, you may go into the room thinking, well, I'm just going to drop off a dietary tray. And then once you get in there, the resident says, oh, I've got to go to the bathroom. Can you help me go to the bathroom? And then you're going to have to go all the way down the hall to go get your PPE. So you want to make sure that it's readily available so that people are going to use it, because this is very similar to what we talked about earlier in the hand hygiene presentation, that they're not going to use it if it's not readily available. And so you need to have your PPE readily available for staff. Position trash can close to the door for PPE doffing. And I would also add that you want to make sure that you're emptying the trash frequently, because when you start using more gowns and gloves, you're going to fill that trash up really quickly. Clean all reusable items before using on another patient. And so this is really the same as we've always recommended, to clean and disinfect reusable items in between patients and residents. Always perform hand hygiene before and after contact with the resident or patient and or their environment. So these are some of the key points that we have used for a long time with other types of transmission-based precautions, and they are also included for the most part in standard precautions. Now, the other thing that I will tell you about enhanced barrier precautions that's similar to transmission-based precautions, if you're wanting to save PPE or try to conserve PPE or just reduce the amount of effort, you want to bundle activities together. So if you know that you're going to have to do some of those high contact activities with a resident, try to bundle those activities when you're already in the room and you already have your PPE on. And that's really going to reduce some of that PPE usage, which has been a big concern from some long-term care facilities. And it's also going to reduce the effort for the healthcare worker. So how does EBP apply to other settings? Because I mentioned at the beginning, if you're in an acute care facility, I want you still to listen to what I'm talking about and be familiar with EBP. So EBP is only recommended for long-term care facilities. So if I work in an acute care facility or I work in another post-acute care facility, why do I need to know about EBP? Well, the reason that you want to know is there may be instances in which a resident comes from an acute care facility in transmission-based precautions, but then they can be changed to EBP and vice versa. And so you might have a resident that is coming to your acute care facility in enhanced barrier precautions, and the nurse may tell you that in report. And so you need to know, why are they on enhanced barrier precautions? And in the acute care facility, is that going to mean contact precautions, or is that going to mean standard precautions? So it is important that you're familiar with it, as well as you might have family members. If someone's been enhanced barrier precautions, let's say, for instance, you have a resident that's being admitted to the acute care facility. They were on enhanced barrier precautions in the long-term care facility because they had a central line. That's the only reason they were on enhanced barrier precautions. So when they come to the acute care facility, they don't require any precautions except for standard precautions. And so you might have a family member who's confused, who says, well, when I was when we're at the long-term care facility, they're wearing gowns and gloves. Why aren't you wearing gowns and gloves? So that way, if you're familiar with what enhanced barrier precautions is and how it's only used in long-term care facilities, you can then communicate that to that family member so they don't think that we're doing something wrong in the acute care setting. Because sometimes that can happen, right? Whenever we're not communicating back and forth and with families, then they get the impression that one of the groups is doing something wrong. And then also there's that increased need for handoff communication with specific details, like we talked about with the wounds. An acute care facility, a draining wound, we're going to put those people in contact precautions. That being said, when they get transferred to the long-term care facility, if that drainage is able to be contained, they're going to go into enhanced barrier precautions. So it's going to be different than what it was, but there's going to be that additional communication needed that maybe you were not giving in the past. And then, as I mentioned, families may need that additional education and information because they're learning these things as well. And remember, some of these residents, they have lived in this long-term care facility maybe for years. And now all of a sudden, staff members are starting to wear gowns and gloves. And that's something new to the family. And they're not understanding, why are we doing this now? And so that may require some additional education. So I want to take our last few minutes before we get into questions to practice a couple of case studies. And so if you want to put your answer in the Q&A, and let's see if I can see the Q&A. Okay, yeah, I can't see it. So I want you all to put your answers in the Q&A whenever we go through some of these questions here. So here's our first case study. Mr. Bob Green is a new resident at a long-term care facility. The receiving nurse was told in report that he has a chronic leg wound that is draining. The wound was cultured and revealed the presence of staph epidermidis. What precautions do you think would apply to Mr. Green? I'm going to give you all just a couple of minutes to put your answers in the Q&A, or I guess we can use the chat, can't we? We can use the chat. Oh, I see a lot of people. Okay, a lot of people putting C. Somebody put D. Person put B. Okay. All right, we've got a lot of answers here. C is definitely the most common answer. Okay. And I just want to start by saying this one is a little tricky. This is a question that comes up a lot, and it is a little tricky. So the answer is actually D. So let me tell you why the answer is D. And as I mentioned, this one's a little tricky. With wounds, remember, the main condition is not only drainage, but if it can be contained. So in this scenario, we don't know if the drainage can be contained. We know that it's draining, but we don't know if it can be contained. And I threw in a little red herring there with the staph epi because that's not a multi-drug resistant organism, but I have had IPs ask me about staph epi before, or staff nurses ask me as well, because when you look at the when you're looking at the CNS, oftentimes staph epi is resistant to multiple antibiotics because that's just part of the nature of that organism, but it is not a multi-drug resistant organism. And so this one is D because we need to know if that wound, the drainage can be contained. If it cannot be contained, they would go into contact precautions. If it can be contained, they would go into EBP. So let's try another one. Mrs. Sheila Smith is a nursing home resident at a long-term care facility. She recently developed acute diarrhea at the facility and was placed in contact precautions. She is being transferred to an acute care facility for dehydration. What precautions apply? See lots of B's. Lots of B's, lots of B's. Wendy, okay. All right, you guys are correct. Contact precautions. So this one, she has acute diarrhea. And so she's going to be in contact precautions because remember, if it's acute diarrhea, we don't really know the cause of the diarrhea. We're still going to put her into contact precautions. Acute illness, that's still going to apply. So our last case study is Mr. Jack Connor, who is a nursing home resident at a long-term care facility. He recently developed urinary retention. He does not have a history of MDROs or acute infection. His primary care physician ordered a Foley catheter placement. What precautions apply? Okay, I see lots of answers. Thank you guys so much for participating. Excellent job. This one is enhanced barrier precautions. The reason it's enhanced barrier precautions is because he has a Foley catheter. So this is what makes it a little different. He doesn't have an MDRO, he doesn't have an acute infection, but he has a risk factor for a multi-drug resistant organism, which is that indwelling device. So remember, we're looking at anything that's going to put the resident at more risk of having an MDRO. So we're looking at those indwelling devices and we're looking at those chronic wounds. Okay, as I mentioned earlier, these are the references, and primarily I just used the CDC guidelines, those two documents that were on that screenshot at the beginning of the presentation, and then also that QSO memo from the CMS, the Centers for Medicare and Medicaid Services. So this is my contact information. If you all have any questions for me, if after I know we're going to have a few minutes to answer questions, but if I don't get to your question or if something else comes to you while you're in the shower or after the presentation, feel free to reach out to me and let me know your questions. So at this point, Julia, do you want to read the questions for me? It looked like we did have quite a few questions there.
We do. We do have quite a few questions for you, Missy. And like I said before with Chad's, if we run out of time on the questions, worry not. We will post the questions with the answers on our website so that everybody has access to them. So we will start with what about going in to perform range of motion and splinting? Would you put on the PPE for that activity?
Range of motion and splinting. Okay, so we're talking more about physical therapy services. So in general, if you are having that close contact, remember we're thinking about contact with a resident that could potentially spread a multi-drug resistant organism to your hands or your clothing. So I think it would really depend on, what is that level of contact? Are you having very close contact with that resident in which you think that the clothing could become contaminated? And if you think that it could, then yes, I would include that as a high contact activity.
Great. All right. What about dialysis ports?
But also, I'm sorry, I do want to say though, remember that EBP is only for those residents with an indwelling device or a wound. So it just wouldn't be anybody I'm going in to do therapy services. Only those particular residents would you be considering wearing gowns and gloves. So just want to throw that in there as well.
All right. What about dialysis ports?
So dialysis ports, it's going to depend, like I said, if there is that external communication with the environment. So if we're talking about a fistula, in general, that's going to be no. If we're talking about like a VASCath or another type of central line catheter that has an external port, it's communicating to the outside, there is a tube coming from the resident, then yes.
All right. Thank you. If the resident's only reason for EBP is wound, do they only need to gown up during the treatment of the wound? The wound drainage is contained for the rest of the day. Do they need gowns and gloves for other care?
Yes, they need to do it during any of those high contact activities. Because remember, the studies show that the indwelling medical devices and the chronic wounds are making that resident more susceptible to multi-drug resistant organisms. And so anytime you're doing any of those high contact activities, you could be coming in contact with the multi-drug resistant organism.
Thank you. What about port accessed for antibiotic therapy or IV fluids? Do we need to put in on EVP or put in EVP, excuse me, for the time the port is accessed?
Yes. So if you have that external communication to the outside, then yes, they would need to go into enhanced barrier precautions.
Right. What about going into, I said that one twice. I'm sorry. A resident here has MRSA of her knee replacement. She does have an area to the knee that opens and closes due to this. Would she still be an EVP when the area is not open?
No, unless MRSA is one of the MDROs that's an epidemiologically significant one for your facility. So remember on that one slide that I showed you the different organisms. See if I can find it real quick and we can look at it again. So remember that MRSA is included on this list if you have deemed that that's one of the ones that's epidemiologically significant for your facility. So you would want to think through that, talk to your public health department or someone from your local health department. Is that one that you should consider for EBP? But if they're just on EBP for the wound, then once that wound heals, then they would no longer meet the criteria unless they had, an invasive device or met one of the other criteria.
Thank you. Would this apply to skilled nursing facilities as well?
Yes. Skilled nursing facilities are included under the umbrella of long-term care facilities.
Can we place the isolation station on the back of the door in the rooms of residents who are in EBP?
In general, we do not put PPE inside a room unless it can be completely enclosed. Like some rooms have those cabinets that, communicate inside and outside. We do keep gloves in the room, typically right at the threshold. I would, that's hard to say black or white, yes or no. In general, you don't want to put PPE in the room just because there's that risk for contamination. So I would say if you're even considering that, it would have to be in some sort of enclosed container. But best practice is to keep your PPE outside of the room when you're using it for precautions.
Thank you. All right. Do we need to put used PPE in red bags?
So this really depends on if you have any state law about using red bags above and beyond the OSHA bloodborne pathogen standard. So if you do not, then no, you would not put it in a red bag unless it meets the criteria per the OSHA bloodborne pathogen standard, which states it has to be saturated with blood or body fluids or caked with blood and body fluids. So if if it's just PPE that you're using for enhanced barrier precautions and it doesn't meet those criteria of being saturated or caked, then no, I would not put it in a red bag for EBP.
Great. All right. Do colostomies require EBP?
No.
For clarification, do urostomies need to be in EBP?
No.
All right. Let's see here. The language in the memo for CMS stated to be discreet with identifying the residents on EBP. The signage isn't very discreet. I read in some of the information that has come out that the signage could be in areas visible to staff, i.e. break room, locker room, etc. as long as staff knew what they were to don and wear. The signage also lessens the home-like environment when you have 1/4 or more rooms on EBP. Are we incorrect on this?
So I think, some of this has to be worked out within your facility, just like other infection prevention measures. The main thing is you need to have a process in place. And for most of our infection prevention measures, specifically with isolation precautions, we know that if you have new staff, or for instance, environmental services, as I mentioned, might be going into those rooms, you need to be 100% sure that if you do not have some sort of indicator on the door, that it's not going to be missed. So that would be my only caution to you about not having something on the door. Everyone who works in the facility would need to know that they needed to wear gowns and gloves in these instances. I understand about the sign and wanting to be more discreet. I totally understand your point of view on that. But also, I think, especially at the beginning, while staff are still learning what those high risk activities are, it's nice to have those listed there. So that they're not having to constantly think back, okay, is this a high contact activity or is it not? And then also, as I mentioned, those staff who may not regularly go into the break room or know the history of the resident, are they going to know if they do something that would put them at higher risk or have one of those high contact activities? Are they going to know to put on gowns and gloves? So I would just say use caution if you choose to do something like that.
All right, thank you very much. I think that Chad, one of our presenters from before, wanted to make a comment. There are multiple other questions. So Missy, not unlike we will do with the other individuals, we'll just send you the list of questions and work through drafting responses, and we'll put those out for everyone. So fear not, your questions will be answered. Feel free to continue to put those into the Q&A. And we'll work to make sure that those questions get addressed and are provided for you all. Chad, did you have a comment that you wanted to?
Yeah, quick comment. Well, first of all, great presentation. It was excellent. But my comment, hopefully this provides a little bit of an aha moment. I meant to mention it during my presentation, actually, but concerning colonization, especially of these MDROs, CRAB, CRE, they colonize in the gut. So if you're scratching your head as to why something might be a high risk activity, it's because this colonization happens in the gut. So often we see that, oh, this person no longer has a wound that was infected with an MDRO. Why do we need to continue? Because now that CRAB that was in the wound is colonized in the gut, and it can also colonize on the skin. So when thinking through why, sometimes think about where the colonization is occurring, and it's on the skin a lot of times and in the gut. Thank you.
That's a great point. Thanks for bringing that up, Chad. And as I mentioned, these really have been as a result of studies. You might be thinking, why are we just focusing on these particular activities and these particular devices? These are based on studies that were done in long-term care facilities and identified as the ones that are causing the most risk or pose the most risk. And we're trying to be as least restrictive as we can in the long-term care facility. So that's why they've really honed in on these particular devices and activities. Thank you all so much for your participation and attention.